Assalamu alaikum. Let's dive into neonatal respiratory distress syndrome. Before this discussion, I would like to see some questions. Start with this. This neonate 45 minutes ago, this neonate is born 45 minutes ago in the NICE is evaluated in the neonatal ICU for tachypnea. He was born at 33 weeks of gestation, rupture membrane at delivery, minimal clear amniotic fluid, no fever, pulse 160, respiration 66, pulse oximeter is 68, only 68% on room air. Okay. Examination show nasal flaring, intercostal and subcostal retraction. Okay, there is decreased breath sound bilaterally. Chest X-ray show low lung volume. This word low lung volume with diffuse ground glass opacity. Low lung volume, diffuse ground glass opacity. Continuous positive airway pressure is provided, but the patient develops worsening respiratory status and is subsequently intubated. Which of the following is the most likely cause of this patient clinical presentation? Looks like NRDS, Neonatal Respiratory Distress Syndrome. Only 33 weeks of gestation, so there may be surfactant deficiency, and we know that surfactant actually causes decreased surface tension. As there is decreased surfactant, so more alveolar surface tension. So this is the right answer. Okay, in NRDS, neonatal respiratory distress syndrome, there is surfactant deficiency in premature infant. He is 33 weeks of 33 weeks baby, so premature. And alveolar surface tension, surfactant actually increase alveolar surface tension and causing diffuse atelectasis. So surfactant deficiency increase alveolar surface tension causing diffuse atelectasis. VP, ventilation perfusion mismatch, causes right to left intrapulmonary shunting. So it causes right to left intrapulmonary shunting. Clinical feature like tachypnea, there is tachypnea, retraction, grunting, cyanosis, hypoxia, decreased breath sound, and these clinic chest X-ray finding diffuse ground glass opacity on CT, and there may be air bronchogram and decreased lung volume. Sorry, in chest X-ray there is a diffuse and ground glass opacity, air bronchogram is present, and decreased lung volume. Management is surfactant administration, respiratory support, continuous positive airway pressure. If it is not improved, then mechanical ventilation should be done. In here it has been done. Prevention is antenatal corticosteroid stimulate fetal surfactant production, and the higher complication is bronchopulmonary dysplasia, BPD, chronic lung disease. Okay. The premature neonate likely has respiratory distress syndrome due to surfactant deficiency. Okay, this is the picture of the diffuse atelectasis, diffuse ground glass opacity. This is diffuse ground glass opacity, and this is the AR bronchogram. This is the AR bronchogram, diffuse ground glass opacity, AR bronchogram. In general, around 20 weeks of gestation, alveolar cell begin to produce surfactant. Surfactant is the primary component composed of this phospholipid, which reduces the surface tension. The quantity and the quality optimal phospholipid composition of increase throughout the gestation. Okay, now look at this question. Mm, Okay, look at this question. This patient, this neonate, a neonate like 28 weeks of gestation, so premature, 34-year-old woman, gravida 4, para 4, spontaneous vaginal delivery, okay. Upgar score is low, okay. Now pulse oximeter 84% on 30% oxygen via continuous positive air pressure. So pulse oximetry show 84% saturation, and the patient perioral cyanosis, neck is supple. Okay, lung examination, grunting, decreased breath sound bilaterally. Grunting, decreased breath sound bilaterally. The abdomen is soft. Hemoglobin is 14. Platelet normal. Most likely cause of these patients hypoxia. Premature infant, 20 weeks of gestation, maybe due to surfactant deficiency. Mm, and it's premature baby. Uh, Pulse oximetry shows saturation lower, perioral cyanosis, and decreased breath sound bilaterally, looks like in NRDS. So NRDS, in here there is increased intrapulmonary right to left shunting. There is increased interpulmonary right to left shunting. So ventilation perfusion mismatch due to right to left shunting. So NRDS, deficiency of the surfactant, okay. A surfactant normally decreases surface tension at the air fluid interference of the alveoli. Therefore, deficiency results in increased alveolar surface tension and diffuse atelectasis, lung collapse, as well as pulmonary inflammation and edema. The area of the collapsed lung are perfused but not ventilated. This word is very high. This ventilation perfusion mismatch, how this happening? The area of the collapsed lung perfused but not ventilated, with resulting intrapulmonary right to left shunting, leading to deoxygenated blood, leading to deoxygenated blood being delivered to the left side of the heart. Deoxygenated blood is delivered to the left side of the heart and to systemic circulation. As in this patient, neonates develop respiratory distress, grunting, decreased breath sound due to diffuse atelectasis immediately after birth. Right to left shunting results in cyanosis and hypoxia, and that is responsive to oxygen administration. Complete blood count is typically normal. Treatment is surfactant administration and respiratory support. Okay, the final question of the NRDS. Okay, look at 28 weeks of gestation. Again, preterm. Okay, good. The patient mother received antenatal corticosteroid. Good. Uh, the patient requires back valve, mask, ventilatory support. Okay, Apgar score is 3 in 1 minute. Very, very poor. The infant is now crying, breathing spontaneously. Okay. Oh, chest radius of shows. Look at here. Diffuse crown glass opacity bilaterally with low lung volume. Diffuse ground glass opacity bilaterally with low lung volume. An air bronchoscopy looks like respiratory distress, neonatal respiratory distress syndrome. And in here, the trunk and the head appear pink and are well perfused. Initially, skin shows cyanosis in the hands and feet. Uh, there is cyanosis in the hands and the feet, but head appear pink and well perfused. Okay, so what is the next best step? Next best step, first provide nasal CPAP. Okay, so NRDS, neonatal respiratory distress. Is there apnea or gasping? If there is apnea or gasping in this patient, there is no apnea or gasping, no. So non-invasive positive airway pressure CPAP, consider surfactant. If there is apnea or gasping, yes, valve, mm, bag valve, uh, bag valve mask ventilation should be given. Then continuous if there is continued apnea, yes, so intubate the patient, chest compression, consider surfactant. If no, then non-invasive CPAP should be given. Okay, now our okay, look at here, NRDS, neonate with respiratory distress syndrome. If there is an apnea, or gasping, no nasal, non-invasive positive airway pressure or CPAP, or consider surfactant. If apnea or gasping is yes, back valve mask ventilation. Continued apnea, yes, intubate the patient. Chest compression, consider surfactant. No, then again CPAP. Okay, what is the treatment? Nasal CPAP with PEEP, 3 to 8 centimeter of water, which prevents collapse, and administration of artificial surfactant within 2 hours of the postpartum. Okay, the differential may be transient tachypnea of the newborn, also known as lung disease, wet lung disease. Full term neonate boy born by cesarean section, lungs are full of fluid, and therapy should be focused on like supportive care. So this is all about NRDS, Neonatal Respiratory Distress Syndrome. Hope you enjoyed.